with on this project. So my session is going to be the youth-led innovation in ending AIDS. We are going to see how they are powering solutions and disrupting the barriers. We are going to be focusing on a project to implement with AIDS Healthcare Foundation around Africa in the countries of operation. So AIDS Healthcare Foundation has a program called the Girls Act and the YPP program, that is the Young People's Program. So under this, the AHF AIDS Healthcare Foundation did a pilot of this project in 2016 in Uganda, where they were targeting girls in cohorts from the areas that had a lot of challenges that girls face, I will say, for example, from the slum areas. And they were empowering them in groups where they would meet occasionally to discuss around SRHR, HIV, and they even empowered those who were willing to go to school by funding them to go back to school. So it was a successful thing. They later on rolled it way around the globe, where AHF operates in all the 38 countries globally and the 15 in Africa. So the Girls Act was a global and a girl-led program empowering girls to be healthy and such that they can be able to thrive. The program was to build their leadership skills, take charge of their health, improve their community, and also engage with stakeholders to be the advocates of change. And we can see with other many countries from Uganda, it grew to Kenya, South Africa, we are now in Nigeria, Eswatini, Sierra Leone, and many other countries. So, but our core values of this project remained central to HIV prevention, since as an organization, AIDS Healthcare Foundation, our major central point of focus is HIV prevention. And also then we looked at empowering them to make healthy decisions, SRHR. As I have already told you, the project also looked at educational support. Under this project, they look for girls who are, they select the vulnerable girls who want to be in school. They are given school fees support, and some are given scholastic materials, but also ensuring that the centers where these girls meet, they have a counselor to handle their mental health for those who need counseling at one point or the other. As we see that they also gave them skills building. The photo down there is for our girls in South Africa who that this cohort said for them they would love to get a life skill where they can do makeup, and they started their own company that does makeup within their country. So it has been a success. The girls up are from Rwanda. So you can see that it keeps on growing. As I've already told you that our reach and impact is in 35 countries throughout the globe where AHF operates. And our other central point that is key to the girls, we all know menstrual health remains a challenge to the girls globally. So the Girls Act program ensures that the girls who are within our cohort and in the community where the cohort thrives do receive sanitary wear. But our major achievement is not the sanitary wear. We are seeing that just in Africa, every month, these girls are able to reach out their fellows who are over 4,500 per month with the HIV information and SRHR information, because we empower the cohort to become ambassadors of change in the areas where they live. Then they come and tell us the challenges they have met in those areas. Another outstanding thing is that they engage in stakeholder engagement with their local leaders to ensure that local governments can come up with bylaws that protect the young girls against, for example, teenage pregnancy, that protect them against gender-based violence and many other things. I have already highlighted the others in line with economic empowerment, school fees support, and mental health hygiene. So that is some of our work. I think the first picture was in Eswatini or Sierra Leone. Forgive my remembrance. Then here we were celebrating the International Women's Day in South Africa. Next slide, please. So the ones in Uganda were able to carry on stakeholder engagement with the Minister of Gender and Social Development. In line with this was the International Women's Day, where they were looking at how they can address barriers to ending gender-based violence among adolescent girls and young women in Uganda. So away from that, as I've already told you, you will say, why is our focus only girls? It's not like that. So we focus on the girls in specific areas of operation, like the slum areas, but our central point of view aims at ensuring that the boy child is not left behind, because empowering the girl child without the gentleman takes them back to the same men who will expose them to danger. So we have our YPP program where we also engage the men in the similar program, but this one is central to ensuring that men are part of these discussions. So under the YPP, since I've already said it's central, these people do counseling and guidance. They act as treatment supporters to people living, to their fellow living with HIV, and also train them to become better citizens. Next slide. So our key issues were that we highlighted that with this YPP program, it was able to support the non-suppressing people living, young people living with HIV. Their retention in care improved because every time we assigned them their fellow young people, they would keep their appointments. Their follow-up was is their retention in care, and those lost to follow were easily traced back with an element of psychosocial support, as we have already. Next. So our key take homes from this program were just one that, due to time, I will just let us run through it, that mentorship is key in capacity of all these programs, because we have mentored them to live even without us, that even in our absentia, they can teach their colleagues. And also paying data, I mean information as your programming is key, because we never implement our project where we feel there is no need. We engage with the district or government officials to highlight what their data or information says about gender-based violence, what it says about teenage pregnancy. And then the Girls Act program targets those specific areas, while the YPP remains in the broader picture of our countries of operation. I think that's all. I thank you all for listening to me.
Good morning, everyone. We just wanted to find out if there's any questions regarding the presentation. I'm coming to you. So please, can you grab your mic to answer as well? Thank you.
Good morning. I am Samuel. I come from Ivory Coast. I speak French. I want to know some things. Do you work in French-speaking African countries? If so, which ones? If not, why not?
Oh, thank you very much. AIDS Healthcare Foundation, being an international organization that has been in Africa for the last 24 years, and their main area operation countries have been East and Southern Africa. But over the years, they decided to move to West Africa, where they are now in Nigeria, Sierra Leone, and this year we are moving to Ghana. We have decided to also take on Senegal next year as our first French-speaking country. So come next year, we shall be in Ghana, and an organization is open to keep to growing each and every year. Thank you.
Any more questions?
All right, thank you so much, Joseph. I think you raised a point around also working with young men and boys under the Girls Act project. So I wanted to follow up more to say, is it more on empowering the boys, or it's maybe having the boys supporting the girls under the project? Because you see, we are doing of more girls empowerment, but in the process, we are now having, we might even risk having young women who are more empowered, and you won't have a young man who is able to handle the empowered woman. So I wanted to follow up to say, is it more of also counter empowering the young men and also challenging issues around negative male masculinity and so forth?
Exactly. Our program, as I've already told you, whereas the Girls Act empowers the women, the young people's program that we internally call the YPP looks at integrating these people, integrating the discussions about adolescent girls and young women, and then with the men. So during these trainings and empowerment sessions, we are looking at masculinity, we are empowering the men to become better, to also ensure that we counter gender-based violence in future. Because if we empower the girl child alone through the Girls Act program and we are sending them to a community that is not transformed, it poses a risk towards our change that we are aiming at.
Okay. All right, thank you. So this session is about now I know my status, what next? And it's meant to have been taken by Franca, but unfortunately due to some issues this morning, she's not here. She's the founder and team lead of Ladasha Development Initiative. She's a youth delegate from Nigeria. Next slide, please. So it's meant to be a youth capacity building session for 45 minutes. We don't have time to do all this introduction of participants. So, okay. We're also meant to have innovative discussions and sharing of IC materials, and also have interactive network for post-ICASA. Oh, sorry. Oh, what did I do? Okay, good. So, what the target audience here is meant for young people, key population, and advocates. And what this session is meant to do is to help around having discussions surrounding youth mentorship, taking further responsibilities within the African communities, sharing best practices across Africa with success stories and lessons from our organization, and inspiring the next generation for African change makers in global health, especially girls and women's health. And we have youth advocates all seated here who would also be having questions, and then they'll be responding to it. So this is the session objectives. I'm not going to go over that because I want us to have enough time for the panelists. But the expected outcome is for us to have increased knowledge, strengthen youth networks, more formidable international youth community, and particularly capacity building of women and girls. So this is just about real stories, and that's what brought about us having this session. I recently heard a story from a friend about how she was saved from contracting HIV by abstaining from random unprotected sex with their fiancé. Another was the premarital testing in her church later revealed that the fiancé was positive, and unfortunately he's dead now, but she's now happily married with children. Abstinence saved her life. Helping and guiding young people through mentorship to make informed choices is key to reshaping the narrative on strategic HIV prevention programming. And also promoting intentional and safe voluntary testing is also key. So this plenary intends to engage youth in constructive, thought-provoking discussions that will stir and inspire them to take fresh, innovative actions for prevention of the virus within their community. So before we go on to recommendations, so I think we'll just quickly go now to the panelists. So for the panelists, we have questions that you're going to take. And permit me, I'll just go into those questions. Now, I'm going to be starting with Bongi. Yes. Practically, how do you suggest that we turn all that we have learned from this conference into action, stopping further infections, especially amongst adolescents in Africa? And I would like you to give us real-life behavioral changes, especially for adolescent girls and young women, now in settings where they are displaced or they do not even have access to education. Thank you.
Thank you very much. Firstly, my name is Ndhlovu from Eohealth Foundation. And what we do is that we provide health literacy, but in a digital platform format, because we believe that that is where young people are. And this is a very critical question because we see conference after conference, we see engagement after engagement, but the only way that we can start tracking impact is if we take what is discussed here and make sure that it lands to the people who really need the information. So at Eohealth, what we do is that we specifically attend events such as these so that we can then go have content online that we can change and make it palatable to young people and then disseminate it, because therein lies the gap. I think what we've seen in our interaction with young people is that there's just two types of young people. It's either you're health literate and you get it, or you're not. And unfortunately, when we come to such conferences, we're speaking to each other as health literate people. And it almost seems so obvious. Like, for example, in South Africa, when PrEP first came through, we all thought it was a miracle drug. We were excited because it's us speaking to the choir. And as it landed on young people's ears, they were the first to say, oh, hell no. A pill every day to prevent, a pill every day. And that's just a typical example of why it's important to then try and package health literacy in a way that is palatable to young people. So if we take it a step back and we go, whose responsibility is it to teach young people to be health literate? That is one of the first challenges that we have, because there isn't a sole responsibility, because within the Department of Education, I don't know about other African countries, but in mine specifically, there is what we call life orientation class, and that life orientation class only has one module that they cover throughout the whole year that covers health. And sexual health is even a unit in that module. So you can understand that something that is so serious that can affect young people can technically only ever have that source of reference, which doesn't even resemble their lives most of the time. So we then have a challenge of whose responsibility is it to provide the health literacy, where the parents are saying the teachers should be doing it, and the teachers are saying, no, this is a home discussion. And the NGOs, as we are excited from ICASA coming back with all these high jargon words like lenacapavir, PrEP, and Eravir, and treatments and testing. And as a young person, you are left going, this does not sound like me or something that I should be doing. So then the question is, who's supposed to be doing that? How are we supposed to be reaching young people? And how do we ensure that as healthcare workers or healthcare professions, we leave the jargon behind and we start engaging with young people in the way that they talk, in the places where they engage, and also understand that we are competing with other information that they are consuming as well. Right now, we are consuming with entertainment, we are competing with fashion brands, we're competing with alcohol, we're competing with sports. And so how then is this health information going to be positioned in such a way that it is information that young people think that they need? And therein, I think, lies the work. Thank you.
Okay, so thank you very much. So what you've pushed out to everyone is we need to ensure that young people are literate, particularly about comprehensive HIV information, because it's one thing for us to sit in one room to create the information content. It's another thing for you to go out. You have parents pushing it to teacher, teacher pushing it back to NGO. So it's meant to be a collective action. Parents, the education system, the non-even education system, and the NGOs working together to ensure that young people are actually health literate. And I think you've covered what are the hindrances to abstinences, because young people do not have information. And they don't have information in the language that they understand. So that's one thing. We must ensure that in putting out our content and putting out our information, it has to be one that young people resonate with, that they understand, and it's easy for them to be able to use to influence their practice. Thank you very much. So we're going to go to Daniel. Daniel Lovier. Is Daniel here? Okay, you're representing Daniel. Thank you. So we're going to take you through, do you have any best practice and innovative strategies from your work that you have done in your country that you can share with us to encourage that young people are able to take self-tests, know their HIV status, and stay protected?
Thank you so much. Back in my country, Uganda, I support a project, as I've already shown you, the YPP program. Under this program, we ensure that the young people get a safe space. So under this safe space that is within a government facility that we attain through great advocacy and ensuring that the young people need a safe space for them. So under this safe space, we have a young fellow male counselor or young girl who is their fellow counselor, who is always there from Monday to Saturday, ensuring that when these people walk in, they can be able to talk to them, and she guides them through the service that they intend to get to. And it is way beyond what service they intend to, because we are in an era of choice. Sometimes when they walk in and the commodity or service they need is not being provided by us. For example, some of them come in need of Kabla, because in my country there are facilities that are already doing the Kabla. These people have been empowered. We have given them a database whereby they can be able to refer this person to a facility that has a service this person desires. Because this is an era of choice, you cannot tell me you can use this if I tell you this is what is comfortable for me. So we find that this is working, that they are continuously coming back without judgment, because in the previous setting, we have seen our fellow young people, after 1 month, they come for PEP. After 3 to 4 months, they will return for PEP. The old health worker will start judging, will be like, but you, I think I saw you in April and you're back in August. That alone will deprive this young person never to return to that health facility. So we ensured that our services become friendly in a nature that these young people have a language of communication that we to ourselves as young people understand, and the old people may be in presence, but they may never understand even what topic we are discussing at that time. So that alone creates a safe space for us. And away from the safe space, we have ensured that away from returning, we to the people who have tested positive, we have what we call ensuring that they start treatment as soon as possible. Because previously we used to lose these young people by giving them, they have just tested positive, let's give them what they can. But we go on to tell them about You Equals You, that come on, treatment works as a prevention for your loved ones. It is best you start treatment as early as today to ensure that your girlfriend, your boyfriend is protected, or your baby, if at all you're pregnant. So that alone has ensured that these people make informed health choices in line with testing for HIV, in line with being retained into care and starting treatment as soon as possible.
Very much. So what I hear you clearly is that we have adolescent youth-friendly services being provided within our health facilities. That in turn means that we have healthcare providers judgmental, they've been trained, and as such it creates a safe space for young people. They're able to access services, testing, and even prep there in those services. Hearing you also in your presentation that you made, you talked about building capacity of girls, and those girls are able to reach out to their peers, and that way they've been able to encourage others even to go for services, and also to for those who are positive among them to continue treatment. So peer-to-peer engagement is one thing that has helped, and having adolescent youth-friendly services within our health facilities. I know we're all moving towards integration. We are running away from the silos, so having those safe spaces within the health facilities and with trained healthcare workers is the way to go. Thank you for that. We're going to go to Godfrey Kambewa from Malawi. Okay, so you're taking this. All right. How can we demystify HIV tests and curb the stigma surrounding it? From the gender perspective, what is your opinion about, okay, maybe we'll allow you to take the first question and then we move to the next question. Yeah, let's have you. So how can we demystify HIV test and cope the stigma surrounding it? Sorry? Yeah, so that's your question. How can we demystify HIV test and cope the stigma surrounding it?
Okay, thank you. I think maybe that was a mistake. My name is Christy.
Oh, sorry about that.
Yeah,
That's
from
fine.
Zimbabwe. So, as I can say, after demystifying stigma in HIV testing services, what is important is to note that youth mainly participate in HIV testing and counseling services when they are involved in programs like youth testing advocacy. So when youth are advocating for HIV testing services, peers, when they are educating other peers, it became easy and it became easy for other peers to understand what does it mean by HIV testing, window periods and stuff, because peers are more, the message from peers is more stronger than the message that it can go to young people from the elders. So what is important is to ensure that the HIV testing programs are mainly advocated by youth to ensure that other youth are also involved in receiving those services, because they are only youth who knows where to get other youth. Sometimes you find that youth are found in clubs, they are found in sports clubs, they are found in sports clubs, they are found in social media and stuff. So it is important to enroll a young person to advocate for those services to other young people, so that the young people accept what are the decision the policymakers are trying to say and they are trying to implement. Because stigma and discrimination is likely to be suffered, is likely to happen in the community when there is no peer advocacy. But when peer advocacy takes place, what it means is that stigma and discrimination will be attacked, because the peers are more likely to understand the message from other peers.
Thank you very much. So we have that coming again, the peer-to-peer support for testing. And this is very important if we are HIV. Now, from the gender perspective, what's your opinion about GB, gender-based violence, rape, and abuse? And can you tell us, maybe from your country perspective, the role of faith-based organizations, NGOs, or CSOs in reducing the impacts on mental health of adolescent girls and women, particularly when those who have gone through this may have to go for testing, or they may have been infected and have to get services. So let's have your view on that. Still for you. From the gender perspective, what is your opinion about GBV rape and abuse? So tell us the role that CSOs or faith-based organizations or NGOs can play to reduce the impact of mental health of girls who may have been raped, and then at the end of the day, they may have HIV. What can the CSOs, NGOs, or faith-based organizations do, particularly to address the mental health challenges that they may have from this?
Oh, thank you once again. For example, in Zimbabwe, we have NGO, we have organizations which support the mental health system, like the Shantiri organization, that is, I think maybe it is a regional organization in many parts of the Southern Africa. It is also available. So the Shantiri organization is advocate services to do with mental health, and unfortunately, the young peers also offer that mental health support by the Shona symptom questionnaire, which involves which have a lineup of about 15 questions, and those 15 questions, there are some strategy questions that are dedicated to that. If a person answers yes,
to that question or answer no to that question, that person is you need to be referred to a psychological specialist or a clinical psychologist. More so, when implementing the programs which prevents SGBV and GBV as well, we do partnerships with victim-friendly unity. The victim-friendly unity is part of the police force. So what happens is, sometimes you find out that in rural areas, there's this tradition like a young person can be raped by a family member. But when that young person is raped by a family member, that information becomes very hard to reach the police force. So what the channel that can be used, because in rural areas they say if it is a family member, they say no, this is a family issue, we need to solve it as a family challenge. No one must spread it out. So at the end of the day, we find out that case is not going to be reported to the police force. So what does Randiri do? The Randiri cooperates with the chiefs and the headmen. Once it cooperates with the chiefs and the headmen, unfortunately it was last year in November when it planned this program, which is the Not in My Village campaign. The Not in My Village campaign was introduced to the president as a proposal to deal with the challenge of sexual abuse and as well as SGBV. So and the president accepted it. So how does this work? The political system tries to give the power back to the chiefs and the headmen. So Not in My Village campaign is now the power in the hands of the chiefs. Whereby the chiefs will be saying, no, there should be no child marriages in my village. There should be no SGBV in my jurisdiction. So what will happen now is that when anything to do with child marriage happens in a jurisdiction, once let us say it is a child marriage, it is now the challenge. The case is now not in the hands of the police. It is now in the hands of the chief. So let us say a child marriage takes place in a local community. The local community members were also told, once you notice something like that, come and report it to get something from doing so. So what happens is, once a challenge is counted in the community, a family member is likely to go to the chief. I saw this and this and this and this happening to this village. So the chief is not taking the case to the police, but the chief is taking the